aortic stenosis. Aortic stenosis. So we have the right atrium, right ventricle, left atrium, and the valves. Now the aortic artery. Oh, oopsie. The aorta, and the valve is stenotic, very stenotic. So it means that in the ejection, the valve could not open very well. So if the valve could not open very well, we have decrease in the blood that the ventricle can send to the aorta. This is decreasing stroke volume. Decrease stroke volume, and we have more blood in the ventricle. So the end systolic volume is going to be, sorry, the stroke volume is decreased. We have less blood that can go through the aorta, and we have increase end systolic volume, because so the blood stay in the left ventricle. Next, we have the ejection fraction. This is the stroke volume divided by the end diastolic volume, is decreased because the end diastolic volume stays the same. We are not filling more the heart, not less. Just we are sending blood to the aorta less. We are sending less blood. So the stroke volume is decreased. The stroke volume is decreased, and so stroke volume divided by end diastolic volume, if this decreases, so this ratio decreases. This is the ejection fraction. Next, the pulse pressure is going to be the same. We're not changing anything. The end diastolic pressure of the ventricle is increased. We have more pressure in the ventricle. We have an increased afterload. The ventricle has to send blood through a stenotic valve, so this increases. The end diastolic volume stays the same, no change. Now the pressure in the ventricle is increased, but the pressure in the aorta is decreased because we have less blood that is going through the aorta. The patient presents usually with syncope in the extreme cases because we have decreased blood that is going through the aorta. Also, if we feel the carotid pulses, it feels how they are feeling, but it feels very soft and like delay, because it is the time that takes the ventricle to send to the aorta is very delayed. It's taking a long time, relatively, and it is soft because we have less blood that is going through the aorta. Now and we would have a soft S2 heart sound. This is when the valve closes. It does not need to close a lot because it could not open very in the diastole. In the systole, the valve do not open. So in the closing of the aortic valve, it should not take a long time to close it. All right. Next, this is this in the pressure volume loop. Would look something like this. Here we have pressure, here we have volume. This is the normal. More or less like this. Now the new pressure volume loop is, we have the same end diastolic volume, so we begin here. We have a decreased stroke volume and increase in systolic blood pressure. So in systolic end systolic pressure, end systolic volume. So here, and instead of being here, this is the end systolic volume. At the end of systole, we are here. We would be here because it increases, the end systolic volume increases. So it is like here. And the pressure in the ventricle is certainly increased. So it would look something like this. So we could say that the pressure volume loop is like extending it, and here it is diminishing because the stroke volume is decreased. This aortic stenosis would be just like that of stenosis, could be because of bicuspid valve instead of tricuspid, or like calcification, just normal calcification with age. But also the stenosis of the aorta is kind of like the similar pathogenesis of the atheroma plaque. The blood that goes through the aortic valve has the most turbulent flow. So we have damaging like the endothelium and the connective tissue, and all this because of the turbulent flow. That's one. The other is as the increased risk in atheroma plaque formation is with something like diabetes mellitus, hypertension, hypercholesterolemia, smoking, like that. These are also the risk factors for damage to the aortic valve that would lead to stenosis. We also have the differentiation of the cells around there into fibroblasts. We have secretion of tumor growth factor beta and interleukin 1.